Thank you for watching this recording of the Critical Issues in Women's Health webinar. The topic of this webinar is the impact of social and structural factors on maternal health outcomes. This webinar features 5 presenters who are the highest scoring abstract award winners for the Women's Caucus for the 2023 APHA annual meeting. The APHA Women's Caucus is committed to providing a forum for the uninhibited discussion of emerging and often not considered and important issues affecting the lives and health of women. In this webinar, we'll have 5 presenters who will give lightning-style presentations. The next presenter will be Dr. Chanell Haley. She's at Tulane University. The title of her presentation is Maternity Care Deserts in Louisiana and Breastfeeding Initiation Rates. She is the winner of the highest scoring abstract award. The third presenter will be Dr. Farida Yada. She is at the University of North Carolina, Charlotte. The title of her presentation is Differences in Gestational Length at Fetal Death by Maternal Nativity Among Black Women in the U.S., and she is the winner of the Honorable Mention Highest Scoring Student Abstract Award. Our fourth presenter will be Dr. Se-Yan Liu. She's at Montclair State University. The title of her presentation will be a multi-level analysis of state-level structural sexism and postpartum maternal health outcomes, and she is the winner of the Honorable Mention Highest Scoring Abstract Award. Our final presenter for the webinar will be Marina Andreadis. She's at Wesley College, and the title of her presentation is a scoping review of a private insured programs to provide innovative support for postpartum birthing parents in Massachusetts, and she is the winner of the Best Student Poster Presentation Award. Now we'll have our presentations.
Good afternoon, everyone. Again, I am Chanell Haley, a postdoc at Tulane University. There we go. Okay. So, the March of Dimes defines a maternity care desert as a county with no hospital offering obstetric care, no OBGYN, or certified nurse midwife provider. Roughly 36% of all U.S. counties are designated as maternity care deserts. And although this health concern mainly impacts rural communities, it can occur in urban areas as well. So one driving force behind the development of these care deserts is the closure of obstetric care units within hospitals or the closure of a hospital in totality. So there are existing studies that discuss the association between maternity care desert residency and increased risk for poor maternal child health outcomes. So building upon that, we examined whether residing in a maternity care desert was associated with lower breastfeeding initiation rates for women and birthing people in Louisiana. So we conducted a cross-sectional analysis using birth records from the Louisiana State Vital Records Office on all live births in Louisiana for the years 2019 and 2020. And to estimate the association between maternal care desert residency and breastfeeding initiation, we fit a modified Poisson regression model. So in addition to looking at all live births, I wanted to include a within group analysis, and I did so by racially stratifying the data. And then lastly, the maternity care desert data was provided through the March of Dimes. And so we linked that to the birth records using the parish of residency within Louisiana. And then looking at the March of Dimes maternity care desert designations, we classified the data into a 3-level categorical variable based on the levels of access to care. So to the left, you see an image of the classifications of maternity care deserts within Louisiana. Louisiana has 64 parishes, and about 34% of those would be considered maternity care deserts. And to the right, you see the results of our regression analysis. So for the total population or all births, you see that in areas with low to moderate access or no access at all, there is an association with reduced breastfeeding initiation. And looking at the stratified models, you can see that the results are similar for both racial groups. So given the reduced access to care, they also showed reduced breastfeeding initiation. So what our study means, although these results were in Louisiana, maternity care deserts and inadequate access to care should be seen as a national health concern, as this study, as well as previous literature, has shown that it does cause an adverse impact on birthing outcomes and even maternal child health beyond birth. And additionally, these findings support the need for policy reform and the development of maternal and child health initiatives that are focused on the equitable access to care, particularly for women in underserved and rural populations, which are those mainly impacted by this issue. And lastly, continued efforts to address the social and structural determinants of maternal and child health. Okay. So I would like to thank and acknowledge my co-authors and the funding sources behind the study, also the Women's Caucus, and all of you for being with us today. Thank you.
Good afternoon, everyone. Thank you for joining us. My name is Farida Yada. I'm at the University of North Carolina at Charlotte, and I'll be presenting our research on the differences in gestational length at fetal death by maternal nativity among Black women in the US. So fetal death is often overlooked in research. And in the US, the prevalence of fetal death is a significant concern, and it often overshadows even infant mortality, especially in the Black community. And so our study focused on evaluating the differences in gestational length at fetal death while considering maternal nativity status. So to do so, we used vital statistics fetal death data from 2016 to 2020 for the entire United States. And we defined maternal nativity as being either born in the United States or born in another country. And gestational length was categorized dichotomously as before or after 28 weeks of pregnancy. We used a multivariable logistic regression model, and we adjusted for age, the use of WIC, education, as well as birth weight. So this is a secondary analysis to the overall US sample. So in the overall analysis, we observed that the proportion of fetal deaths before 28 weeks of gestation was significantly different based on maternal nativity, notably that foreign-born women overall were 6.4% less likely to experience an early fetal death compared to US-born women. But in the present analysis, focusing on Black women specifically, we observed that foreign-born Black women were 8% less likely to experience an early fetal death compared to US-born Black women. But as you can see, that finding was no longer statistically significant. And here I'm just showing the results of our descriptive analysis and our regression analysis, but for the sake of time, I will move on to the next slide, and we can always come back for the discussion. So to conclude, our study highlighted the importance of considering maternal nativity when addressing fetal death, since it's an under-researched topic in maternal and child health. And it also calls for enhanced data collection to enhance our inferences from the research and to tailor clinical healthcare policies and interventions. Now, this study was just a starting point, and we do hope that our research will pave the way for more in-depth research in the future, more specifically, looking at the specific countries of birth instead of dichotomously categorizing maternal nativity. Thank you.
Hi, everyone. Thank you for joining us today. And the title of my study is State-Level Structural Sexism and Postpartum Maternal Health and Behavior. So the motivation of this is really what we know is just amazing variation across states in terms of postpartum health behaviors as well as outcomes. And this is just one graph from CDC that shows that. One of the driving forces for such state-level variations is really state-level policies. We know that in the US, most of the policies that affect our everyday life is actually not from the federal level, but actually largely driven from states. That means then who represents us on the state level, who's our state politicians, is really going to drive many of the policies that we see that will affect our everyday life. There's emerging literature that shows that structural sexism, as defined as state-level female political representation, is associated with physical health outcomes as well as healthcare access. We also know that on the state level, we are, as females, really underrepresented. I think the 2024 shows us there's only about 33% of state-level politicians that are elected that are female. So what is lacking so far in the literature is really looking at postpartum health and behavior. We know in the postpartum period that there's so many changes in both the individual's mental and physical health, as well as their social and family role, that it's going to be really sensitive to the larger context. So the two outcomes that I was particularly interested in, because it's widely prevalent, and it also has a large impact in terms of long-term health impact for the individual as well as the family, is breastfeeding as well as postpartum depression. So I'm using 2019-2020 PRAMS data, and to account for the fact that participants are clustered within states, I ran a multi-level model that also accounted for the complex survey weights in PRAMS. I included both individual level as well as state level covariates in my fully adjusted model. There's over 77,000 individuals who were in our data set. About 11% reported never breastfeeding, and 15% reported often or always experiencing depressive symptoms after birth. And what we also know is that, and what we also saw in the data set, is there's a wide variation in terms of what we see for maternal, according to maternal race. That ranges for postpartum depression from about 13% for non-Hispanic white and Latinx to over 18% among API others as well as Blacks. You also see the same wide variation among maternal race for never breastfeeding, from 8.5% in Latinx to 21% for non-Hispanic Blacks. When we ran this table, this figure shows the results of our statistical models. And what you see here is that one standard deviation increase in state female political representation was associated with a significant decrease in both outcomes, a larger decrease seen in never breastfeeding. I further examined whether there was effect measure modification by maternal race. I did not find any in terms of postpartum depression, but I did find that in never breastfeeding. So the association between structural sexism and never breastfeeding really varied by maternal race and ethnicity, where the association for Latinx was not statistically significant, but for the other maternal races and ethnicities represented in our data set, it was. So in summary, we do see that state female political representation is associated with decrease in postpartum maternal health behavior, as well as outcomes, and that it might vary by maternal race and ethnicity. I want to acknowledge the limitations for using this data set, but also point out the strengths that is nationally representative, and because it's collected soon after giving birth, it decreases the chance of recall bias. Finally, I like to end it by talking about future directions, to really thinking about the mechanism. I think that we see variations by maternal race and ethnicity because of the specific policies that might be promoted by female legislatures and how that might actually influence certain economic groups and certain maternal race and ethnic groups. And also kind of incorporating the idea of intersectionality and whether state politicians' other identities, such as race, also might influence what programs as well as policies that they're going to support. Thank you.
Hi, everyone. Thank you so much for having me. Today, I'll present on our project titled A Scoping Review of Private Insurer Programs to Provide Innovative Support for Postpartum Birthing People in Massachusetts. So maternal morbidity, as mentioned earlier, represents a healthcare crisis. We often think of maternal health as simply ending with maternal mortality, but also incorporating maternal morbidity tells us a more complicated story. A recent Department of Public Health report from the Massachusetts DPH found that maternal morbidity has nearly doubled over the past decade, reaching about 100.4 severe maternal morbidity cases per 10,000 deliveries. And we really see that differences along ethnic and racial lines are pronounced for rates of severe maternal morbidity. In response to that, a lot of national and international bodies have focused on the importance of timely, comprehensive postpartum care in addressing both maternal morbidity and mortality. And so we're really focusing on these recommendations for postpartum care to address the maternal health care crisis. So we really see an evolving role of insurers in maternal health care. Often we see approaches to insurers focusing on the understanding of insurance companies as payers, focusing on improving access by simply expanding coverage or improving reimbursement. But we know that insurers for other care populations have really moved into the provider space. For example, for diabetes patients, a lot of insurers will supplement care provision with cost-saving case management programs. And one of our lead authors, Dr. Holzer, was enrolled in such a program during her pregnancy by her insurer, which involved a nurse calling her pretty regularly throughout her pregnancy as well as into postpartum to complete screenings that would otherwise be covered by an obstetrics care provider. So we really wanted to see how widespread these programs are and also see if all programs offered are this comprehensive. So our objective is really to identify the variety of direct services provided by insurers in the postpartum period. To do this, we performed a modified PRISMA scoping review. We first identified private insurers through MassGov and the Mass Health Connector websites. We then screened the insurance websites to identify programs of interest. And the programs we included in our sample offered services provided directly by insurer instead of simply reimbursing outside care. And finally, we applied a content analysis to program text we collected in order to identify specific supports offered and also align them with a consolidated list of guidelines from national and international bodies on maternal and postpartum care. So we found 11 private insurers qualified for inclusion for currently operating in the state of Massachusetts. 9 of these actually provided programs that fit our criteria, really providing direct services to people in the pregnancy time. And supports offered included care management, early education on both postpartum self-care and newborn care, as well as the inclusion of an interprofessional care team. The care team, as shown in the table, we found that this included mostly nurses, as well as physicians, social workers, health coaches, clinical pharmacists, as well as mental and behavioral health specialists. Notably, you'll notice none of the programs included the use of midwives. One program in particular really stood out to us for taking a very comprehensive approach to maternal healthcare management. I've highlighted the innovative supports with arrows, but Sunny Start provided by WellSense really seems to coordinate prenatal and postpartum physician appointments, as well as psychosocial and socioeconomic needs through the use of social worker involvement. And this was really unique. So ultimately, we found that in the postpartum period, private insurers were not simply compensating for care provided by others, but really stepping into the providing care space. Model programs aligned with many of the guidelines for postpartum care, but again, none of them incorporated midwifery care models. In providing care, we think insurers can become important partners in postpartum care period to advance maternal well-being, as well as advancing health equity. Next steps for our project will involve direct outreach to insurers and also expanding our methodology to include other states. Future work in this area should really focus on assessing patient enrollment in the programs and who gains access to them, as well as patient satisfaction. And we're really interested in if these programs actually improve health outcomes of these patients. Thank you again for having me, and I thank you to Dr. Jessica Holzer and Dr. Shilpa Lone for their support.
Thank you for watching the recording of this webinar. To learn more about the initiatives of the Women's Caucus, you can visit our website, womenscaucus-apha.org, or search the APHA Women's Caucus on the major social media networks. Thanks.